Here we go. I love how they announce that. Um, and yeah, so I wonder if I could just get you to talk to me just for a minute, just so I can make sure that
Sure.
the levels here are
I'll
fine. And
describe what's happening. I'm in my basement right now, as far away from the baby as I can be because he's loud.
okay,
And I'm locked in here with the dog who might bark, but it looks like he's having a nap, so that's a good thing.
uh-huh,
Stay asleep there,
okay,
buddy. Stay asleep.
oh,
And should I
okay.
keep talking?
No, 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 that sounds fine. I think that sounds okay.
Okay.
Yeah, so I'm going to, I'm going to put myself on mute while you're talking
Okay.
so that I don't capture any of the background noise here. So just be assured that I haven't disappeared. If some people are expecting to hear me, a humming or what have you. So you won't hear that. Um, and um, I guess I wanted to focus on, you know, what made it possible for Canada to reach, to end up at the top of the heap in terms of
Yeah.
first doses, um, and what really needs to happen now, right? Like just that the sort of the success
Yeah.
or not of
It,
that strategy, but what are the sort of because I'm imagining that like obviously the game's not over. So
so to answer the question, what made it possible for us to be in a position to be the world leader in first doses, frankly, is a decision made in a moment of crisis. And that crisis came about because we did not have a sufficient number of doses, and there were none coming on the horizon, at least not in the amounts that people were demanding. We, meaning the federal government, that's not me, by the way, it's the royal we, the nation, had made arrangements with at least 7 different manufacturers to purchase up to 400 million doses, and everybody was quite buoyed by this information because that's 10 times the number of people in the country. But it turns out that those doses were mostly theoretical, or they would be arriving months down the road. Whereas we saw in the UK, in the USA, Israel, better deals had been made and they were awash with vaccines and were on their way out of the pandemic, in theory. So, given that there was a shortage of doses, they had to be rationed. And this was done in an interesting strategic way. Back in December, the epidemiologist Michael Mina had written a paper suggesting that the data around one dose was pretty good and that we should really consider focusing on a one dose strategy so that we can backfill second doses later on. And this was widely rejected as a strategy. Unfortunately so, because it's a valid strategy. Because if you look at the critical trial data at the time with the circulating variant, the wild type COVID classic, as I call it, it seems that one dose of the mRNA vaccines, depending upon how you did the math, could offer 80 to 90% protection, whereas 2 doses offered 95% protection. 80, 90% is pretty good, right? So the question is, can we get away with one dose for a long period of time and stretch the rare commodity that is vaccine wide enough and long enough so that more people get immune? It was a gamble. And when the gamble was first announced, I was skeptical, but I came around pretty fast because I realized a very important thing. And that is, this is not about individual resilience. This is not about getting perfect, or at least as perfect as we can get, protection into a small number of people. It's about getting a sufficient amount of protection into as many people as we can to deny the virus entry points into society. So Quebec kind of made this possible because they were the first ones to take up the challenge back in late January, early February. They decided to extend the interdose interval beyond what the manufacturer had recommended. The mRNA vaccines, as everyone knows, I think by now, the recommended interdose interval is between 21 and 28 days between the first dose and the second dose. And Quebec decided to extend that to 90 days, which was shocking to many people at the time because they said this is a population level experiment. But that gamble paid off. Their hospitalization and death rates started falling pretty quickly after that decision. And so the rest of Canada followed suit with our federal government's advisory committee, NACI as it's called, suggesting that we could wait 4 months between the first and second dose, which is really quite untoward, frankly. And
And sorry, but that was like 4 months. That's no, did any who else had data on that at that point?
right, good question. At that point, nobody had data on it. It was it was a bit of a gamble. So the clinical trial data had some individuals who, for a variety of reasons, had a delayed second dose up to about 90 days. And the AstraZeneca data was showing that 12 weeks was a sweet spot for that vaccine, but that's not what we're talking about. We're talking about the mRNA vaccines. There was a suspicion that 3 to 4 months would at the very least be tolerable because data studies on people recovering from COVID showed that if you're going to get reinfected, it was going to happen after 3 or 4 months, suggesting that on average, people had antibodies in their bodies after recovering from COVID for at least 3 or 4 months. So I think the gamble was based on that. I'm not entirely sure how the decision was made, but I think it's based on that. So with that in mind, with the 4 month, 16 week interdose interval established, then we could go forth and get that dwindling supply, that coveted, delicate and desired supply of vaccine into as many bodies as we can to prevent the penetration of the disease into society. And I think it worked. There's some advantages to this strategy. First is that you get more population level immunity, which is good. It's not perfect, but it's good. Second, you get to work out some distribution issues. So if the original plan was to reserve half of the doses for people's second shot, then you don't get to really experience the challenges of getting first doses into many people early on. And there were many challenges, many of which were unanticipated. How to get to remote communities, how to have the mobile transportation units up and running, how to convince the vaccine hesitant in certain parts of the country to be more compliant, etc., etc., etc. Working through those distribution issues for a first dose means you've got time, if the delay is 4 months, to fix those things for the second dose. Also, it gave them the opportunity to account for some of the boondoggles. Like our AstraZeneca rollout was a bit bumpy, and given the clotting disorder data that came out later, suggesting that maybe AstraZeneca was not a desirable vaccine for some people, it gave time to adjust the second dose strategy to offer mRNA vaccines for those receiving the AstraZeneca shot. So giving that longer interdose interval bought time for that kind of thing. As well, I suspect that having a wider first dose distribution might decrease vaccine hesitancy overall because it might be easier to backfill second doses than it is to convince people of the need for a first dose. So you do that vaccine hesitancy work up front. That might not be accurate because in the US, millions are not showing up for their second dose. So that first dose work may not have achieved much penetration into the vaccine hesitant community. But I think it does.
Sorry, so now what was your role in all of this? Are you an academic who's been watching, and you sort of watching to see what's happening, or have you been playing an active role?
I've not been playing an active role. I'm an academic who comments and observes, and as a result, I'm called upon to comment a fair deal. I have briefed government on my observations. I have consulted to drug companies as well on my take on things, and I've written for newspapers and commented to media on my take. So I like to think that I have no influence whatsoever, but who knows?
Right. Okay. Yeah. Well, I mean, I'm sure you have some influence. But so basically, what I mean, what made it possible was the country government was basically forced into it
Yeah.
to a certain
Now let's be
extent.
clear on who's making the decisions here. The federal government is responsible for acquiring the vaccines and offering guidance on how they should be deployed. For example, the federal government strikes this panel that's called NACI, which consists of vaccine experts who offer suggestions on how the vaccine should work. The provinces are the ones tasked with actually implementing healthcare, which means implementing public health as well and pandemic control. They are not bound to follow the recommendations of NACI. So they weren't, if they wanted to, they could have stuck to a 2-dose strategy. They could have kept the interdose interval to 3 weeks if they had chosen. That's why Quebec has 90 days. Ontario has 4 months. There's a fairly heterogeneous distribution and application of these tools across the board. But everyone is kind of on board with the strategy of delaying a second dose at least a little bit to maximize the distribution of that rare commodity.
Mm. And was there anything sort of like inherently, because this was I mean, I've been here the whole time, as I recall, especially at the beginning, like the logistical problems, everything it seemed like was standing in the way of actually getting the
Yeah.
vaccines into people's arms. But was there something, is there something about the Canadian system that, like the Canadian healthcare system, that also has helped to facilitate getting all these doses out this quickly? Or is it fast
It's a good
even?
question. It's easy to see the errors and not the successes. It depends on who you're going to compare ourselves to. Like in the American case, the vaccines early on were distributed through drugstores. You've got the cooperation of Uber and places like that to get people to the vaccination sites. In Canada, it's been entirely driven by government and our socialized medical system, which has some advantages. It means there are no financial barriers to accessing the vaccine, and everyone has healthcare to a certain extent. You could consult your doctor to for guidance on where to get it and so forth. But the failure is in the communication chain. Many family doctors didn't know what was going on, weren't given vaccines early on to give to their populations. The family doctors in general were not part of the rollout campaign until much later. The drugstores were roped in, before the family doctors were. It's been a bumpy ride, surprisingly so. And my biggest frustration has been watching the data infrastructure not be as resilient and as labile and as responsive as it could be. Even something as simple as canceling second appointments for people who made multiple appointments to get doses is something that should be second nature to anyone who makes databases. Yet that's been problematic. So it has not been faultless by any stretch of the imagination, and there have been some failures of imagination as well. For example, early on, it was clear that we had to get doses into residents of long-term care centers, but there was a challenge in the Pfizer dose because it had to be kept in deep cold storage, and many of these long-term care centers don't have the refrigeration capacity to do so. As a result, some of those groups were bypassed, where the obvious solution is, well, you take the doses to them, or you take the long-term care residents to the hospitals where the doses are. There are
But
obvious workarounds.
are these sort of barriers that are unique to Canada though, or this is something, those are
No, those
things that
are
happen everywhere,
things
right?
happen everywhere, and they come
Yeah,
down to the failure of imagination and of organizational acumen. Things that are
right.
unique to Canada tend to be distance and culture. So we are a large country, obviously. We have a lot of remote areas that can only be accessed via, a float plane and things like that. We have our remote indigenous communities are historically quite vaccine hesitant. So that's been a challenge to convince some of these populations to accept vaccination. We have the spread of misinformation. Now that's worse in the USA, as far as I can tell, but that bleeds over here more so than it does in European nations, for example. The conspiracy theories are ripe here as well, more so than in places like India that really needs vaccines, but less so than places like the USA. So there are challenges, absolutely, but there are also advantages. I think the socialized medical care system has been an advantage. It makes the system a bit more contiguous. You don't have people jumping the queue as much as you would in a situation where there's two-tiered healthcare being offered. We don't have
Right.
celebrities with their own private stockpiles that allows them to have their talk shows up and running or their podcasts up and running because they've got rapid tests on site or vaccines on site. We haven't got that. So there's a more equitable distribution. It's not perfectly equitable, not at all. We do have pockets of racialized people and poor people who desperately need vaccines who aren't getting them, but
So,
more so.
so what, I guess it's one thing to say, well, we've got, we've vaccinated 65 or 66% of the entire population or whatever it is right now. But what difference has that actually made? And especially like the point that we're at right now with the
Yeah,
Delta
I think it's
variant.
made a lot of difference. I think definitely crushing that third wave was done because people agreed to get first doses. In particular, I want to give credit to the AstraZeneca people, the Generation X Zeneca, as they call themselves, who dutifully lined up to get the AstraZeneca shot as soon as it was made available, despite people being trepidatious about that vaccine. And it's hard to quantify how much they contributed, but without question, the crushing of that third wave was due to a combination of government policy, lockdowns, and the desire and eagerness of people to get that first dose. Now, with the Delta variant now looming its ugly head, everything has changed a little bit because, as I mentioned, back when COVID Classic was dominant, the one dose offered between 80 and 90% protection, depending on how you do the math. With the Delta variant, it's probably more like 30%. So it's imperative now that we kind of reverse course and we accelerate that second dose, shorten the interdose interval back down from 4 months down to 3 weeks or as close to as we can get, as close to that as we can get it. So the ground shifts and we must shift with it.
Sorry, the ground shifts and we shift with it.
Yeah, that's right.
But so what kind of, is there any sort of data that shows a direct connection between, the first doses, fast strategy, and crushing the third wave?
It's a tough question. You can make some hand-waving arguments about, the rate of vaccination goes up this amount and the declination of cases went down this amount. However, it's difficult to disentangle other factors, like the closing of schools or the imposition of additional governmental restrictions. All these things happen simultaneously. So it is literally impossible to mathematically disentangle them. But it is a compelling argument, to be sure. More importantly, I think it's more compelling to argue that now that cases are down, we can keep them down because more people have doses in them. And we can further batten that down as more people get second doses because, again, Delta becomes dominant. When Alpha was dominant, B117, that first dose was pretty good. It offered some pretty good protection, maybe 50%, if not more. Right? So it was I would... Again, there's modeling data to suggest that vaccination played a strong role, but it's not conclusive. It's not a slam dunk, but it makes sense.
So there's modeling that was done in advance, or modeling
The modeling is done continuously.
Okay.
There's modeling presented by the Ontario Science Table, for example, showing that if vaccination reaches this amount, then the cases will come down this much. If schools are closed, they'll come down this much. If the two are done together, it'll come down that much. But again, that's all based upon assumptions of the effectiveness of certain things. We don't know exactly how effective school closures are, for example, but there's a hand-waving argument that's responsible for this amount based upon what's observed elsewhere. That's the nature of public health modeling. It's imprecise, and a lot of it is based on hand-waving arguments, which is frustrating for people who don't see it as true science, but it's the best that we have right now.
Right. So we don't know. Maybe the modeling suggests that getting all these doses out that quickly made a huge difference, or maybe it didn't.
Yeah, but another thing that was shown was that during that third wave, while the cases went up, the hospitalizations were concerning, but the death rate was not as high. The case fatality rate came down. That tells us that people were getting sick, but not sick enough to die from it as much as they would have in previous waves. And that to me says vaccination, because vaccination doesn't necessarily prevent infection, even though it often does. Sometimes it just prevents severe symptoms. So people are testing positive, but not ending up in the morgue or in the hospital. Okay. So we look back, the first wave was driven by cases. Second wave was driven by deaths. The third wave was driven by hospitalizations, and the deaths were down. If there's a fourth wave, I don't know it'll be driven by Delta. Hopefully there won't be a fourth wave. But the fact that the case fatality rate was down in that third wave suggests that vaccination was doing its job.
But is there any data to show what percentage of people who ended up in the hospital or who got sick had been vaccinated?
Yes, I don't know the numbers offhand, but there's going to be some breakthrough infections to be sure. If you look at the UK, right now, for example, they're going through a Delta crisis, and
but
Sorry, go ahead.
Sorry, I mean with the third wave, because you're saying the case fatality rate was down and
Yeah.
that's got to be because of vaccinations. But do we know that there was in Canada, that there was a large percentage of people who were maybe getting sick, but not sort of sick enough to die,
Well, not sick enough to be hospitalized either,
or not
right?
sick enough to be
So the
hospitalized?
cases are
But
people who
hospitalizations were up.
they were up, but not, yeah, but in proportion to the number of cases, like they were not in the same proportion than previous waves. Does that make sense? So,
Right.
right, and those being hospitalized for the most part were unvaccinated. But there's a large number of people who are testing positive who are not being hospitalized or dying, and we think that's because of vaccination. Now, the older population, they were prioritized for second doses. Not all of them got their second doses though. So the death rate amongst the long-term care residents dropped really hard for that third wave because they were hardened. And it's I'm talking in circles. I realize because I'm not entirely sure about the numbers. I wish I had them in front of me. I don't. But the assumption, I think it's a good assumption, is that those cases, many of which were registered as the ones that were driving the third wave, might have been single dose vaccinations that did not result in serious symptoms.
Oh, but do those numbers exist?
They probably do. I don't know them offhand. I'm sorry.
But no, but I mean, do you know where I would find them? Like,
Yeah,
are you
the
thinking of this?
yeah the Ontario Science Table website probably has them for Ontario.
Uh-huh.
The yeah, and the Ontario COVID dashboard might have them as well in raw numbers.
The Ontario,
COVID dashboard.
and they would be broken down that way, that the such and 20% of people
It
who
might
actually
be
tested
raw data.
positive.
It might be raw data. You have to download and crunch, but you would think it
Uh-huh.
would be there, right?
Okay, but do you know that it is, or you're just saying you think they must have
The
it?
hospitalization data would probably have it. But if you test, for example, if you go in for a swab test and you test positive, that goes in the database as a positive test. You don't always ask if you've had your shot yet. So that data does not exist for all the people who test positive. Unless
Hmm.
you are serious enough to actually be hospitalized, then a deeper investigation is done. All
Hmm.
these people going through drive-through swab tests, for example, they don't give them a full questionnaire very often.
But it would be the Ontario Science Table that
Yes,
maybe, if the data
right.
did exist. And to your knowledge, has anybody actually done like a formal study?
No, I don't
You know,
know that. I'm sorry.
looking at like sort of empirically at this first dose fast policy. Doesn't sound like it.
I bet someone's working on it, but it's not public yet.
Not public yet, right? Okay, okay. Um, in 3 minutes. But this is now we're at like, what is the sort of the crucial issue right now? Because
The crucial issue is backfilling those first doses. And well, there's two crucial issues. Backfilling is making sure that those 70% all get second doses, but getting to 90% or higher of everyone with two doses. Like there's an advantage in having that one dose. It makes the backfilling easier to some extent. And right now we have demand outstripping supply, which is great, but very soon we're going to come up against that wall where supply outstrips demand, and we have to like pull out all these incentivization tools to get that final lap, that final 20% of people. That's going to be a problem. I have no
well,
concerns about getting to 70% double doses before the end of the summer. Well, before the end of September, but 90% will be hard.
but how important, like is there a timeline with the Delta variant on the rise? Like how soon do people
It's a
need to get their
complicated
second
question
doses?
because it comes down to the rapidity of the reopening strategies. Right now, the reopening roadmap put forth by the federal government and by Ontario are rational. They're according to three sets of indicators: the epidemiological indicators, the population indicators, which is vaccination, and the health systems indicators, and each with a 21-day separation of the stages, with the assumption that if the indicators are all showing the right thing, then you go next. Delta changes the indicators. So if the decision is being made according to the indicators, we're okay. If, on the other hand, the decision is being made according to arbitrary calendar dates, we're not okay. So there is a race of vaccination, second doses, versus Delta. That's the narrative for this final challenge. And if we can resist the urge to open ahead of schedule, then we'll be fine. I've been saying that we have to do 4 things. One, we got to get second doses into everybody and first doses into those who haven't gotten any doses at all. 2, we got to shorten the interdose interval. 4 months was great before. It's got to come down as close to 3 weeks as we can now. 3, we have to prioritize hotspot areas and essential workers like we did last time, but this time for second doses. And lastly, resist the temptation to open early.
Okay. All right. Can you just please tell me, introduce yourself, tell me your name, what your
Okay,
position is?
sure. Hi, my name is Raywat Deonandan. I'm an epidemiologist and associate professor with the Interdisciplinary School of Health Sciences at the University of Ottawa.
Okay, great. Thanks for your help.
Was it useful?
Yes, that was helpful. Yeah,
Okay, good.
thank you.
Okay,
Okay,
bye-bye.
talk to you soon.